Thank you for participating in our Journal Club presentation. And in this series, we have selected various publication reviews, which we hope will be of interest to you. The links to the articles have been shared in our DOBBS Telegram Journal Club group. Please feel free to join if you're not already a member. And in order to claim CPD points, you just need to pay attention to keywords which are mentioned throughout this session. There's also a link posted in our Journal Club Telegram group, which will facilitate you claiming the CPD points. You just need to click on the link and then answer the questions to which actually test whether you have listened for the keywords. Okay, this session qualifies for 1 CPD point via the MMA CPD system. We hope you'll benefit from this session.
Clinical care pathways for non-alcoholic fatty disease. An interdisciplinary panel has published guidance on screening, diagnosis, and management for non-alcoholic fatty liver disease. Because the prevalence of non-alcoholic fatty liver disease is high in the general population, the AGA, or American Gastroenterological Association, has developed an algorithmic clinical care pathway that is appropriate for primary care. And here are the key points. Identify at-risk patients who fall into 3 groups: type 2 diabetes, 2 or more metabolic risk factors, i.e. central obesity, high triglycerides, low HDL cholesterol, hypertension, pre-diabetes, and incidental finding of steatosis on imaging or high ALT or AST on lab testing. Screen at-risk patients for alcohol use and check AST and ALT levels if not done. And patients with elevated AST or ALT should also be screened for other liver diseases, especially hepatitis B and C. Screen non-invasively for clinically significant fibrosis using the FIB-4 score, and the FIB-4 score is derived from age, ALT, AST levels, platelet count, and can be obtained using online calculators. Patients with low-risk FIB scores less than 1.3 can be followed routinely on primary care. Those with high risk should be referred to hepatologists. And those with intermediate risk FIB scores should undergo measurement of liver stiffness using a transient elastography device such as FibroScan. Those with low risk stiffness can be followed routinely, and those with intermediate risk or high risk should be referred to a liver specialist. The document includes a detailed discussion of lifestyle intervention and drug therapies for patients with non-alcoholic fatty liver disease and NASH, which is non-alcoholic steatohepatitis. The Mediterranean diet is recommended. Note that no drug has been FDA approved, but several agents such as vitamin E, glioglitazone, and glucagon-like peptide receptor or GLP-1 agonists can be considered in subgroups of patients. So the comment by the editorial says that this care pathway is worthwhile reading for primary care physicians. It's 8 pages long and easy to follow algorithms and concise, clearly written discussions of the rationale for each step. For areas of uncertainty, the authors allow for shared decision making that incorporates patient preferences. So note that the consultation with hepatologist might not be readily available in certain geographic areas, but I think in Malaysia, it's not a big issue. So this is the reference, Clinical Care Pathway for Risk Stratification and Management of Patients with Non-Alcoholic Fatty Liver Disease, Gastroenterology, 2021, November 161. Okay.
Well, that completes the first journal article presentation and review. So if you are in our Journal Club Telegram group, what you can see is a discussion on that, and we've actually put the link to the FIB-4 score. And also, Dr. Noor Azmi has put a list of medical centers and hospitals in Malaysia where you can get the FibroScan. Okay, so the first keyword to take note is liver. I repeat, the first keyword is liver, and it's all in lower case.
Well, is associated with increased risk for atrial fibrillation. This article is from Circulation, October 6, 2021, and the findings are from a meta-analysis of large-scale randomized clinical trials. So, fish oil or marine omega-3 fatty acid supplements are sometimes recommended for prevention of cardiovascular events, but whether they, as a class, provide cardiovascular benefit remains controversial. And in addition, there is a signal of concern that has arisen that atrial fibrillation risk may be increased with their use. So, to investigate the risks of atrial fibrillation in this setting, researchers conducted a meta analysis of data from more than 81,000 participants of 7 RCTs examining the effect of fish oil on cardiovascular outcomes. Nearly three-fourths of participants were enrolled in trials testing doses of less than 1 gram a day, and the remainder were in trials testing doses more than a gram a day. The participants' mean age was 65, and 40% were women. So during a median follow-up of 5 years, 2,905 patients, or 3.6%, developed atrial fibrillation, presumably new onset atrial fibrillation. The risk of atrial fibrillation was significantly increased with omega-3 fatty acid supplements compared with placebo, the hazard ratio of 1.25. So, when stratified by dose, the risk magnitude was greater in trials of doses more than a gram a day, the hazard ratio 1.49, compared with dose testing less than 1 gram a day. So it appears that marine omega-3 fatty acids carry a real risk for atrial fibrillation, which may increase with higher doses. So for many patients, the benefits of some omega-3s may outweigh the risk, but for patients at high risk of atrial fibrillation or with a specific concern for avoiding it, skipping omega-3 use or at least taking a low dose may be wise. So this is a reference, Genzer B. et al. Effect of long-term marine omega-3 fatty acid supplementation on the risk of atrial fibrillation in randomized controlled trials of cardiovascular outcomes, a systematic review and meta-analysis in Circulation, October 6, 2021.
Okay, that concludes the second journal article presentation. And here's the second keyword for you to take note. And the second keyword is circulation. All right, in lowercase, the second keyword is circulation.
Of painful knee and hip osteoarthritis, a meta-analysis, and this is a review of the article by Da Costa BR et al. In the British Medical Journal, October 12, 2021. In summary, actually none of the treatments are ideal, but topical diclofenac is a reasonable first choice for knee, but not hip osteoarthritis. Patients' responses to drug therapies for painful knee and hip osteoarthritis are unpredictable and often disappointing. In this network meta-analysis of nearly 200 randomized trials, each of which involved at least 100 participants, researchers examined the efficacy and safety of non-steroidal anti-inflammatory drugs or NSAIDs, opioids, and acetaminophen in patients with knee and hip osteoarthritis. Duration of most trials was 6 months or shorter, and the results were as follows. 3 NSAIDs, diclofenac 150 mg daily, rofecoxib or Vioxx, and etoricoxib were highly likely to reduce pain by more than the author's stated minimum clinically important difference, 10 millimeters on a 100 millimeter scale. However, in the US, rofecoxib was withdrawn from the market in 2004, and etoricoxib was never FDA approved because of cardiovascular safety concerns. Topical diclofenac had a high probability of clinically meaningful pain reduction in knee osteoarthritis. No data was available for hip osteoarthritis. Opioids and acetaminophen had low probabilities, less than 50%, of achieving clinically important pain reduction. So the risks for adverse effects were high with opioids and oral NSAIDs. There were no significant safety concerns noted for topical NSAIDs. So many of these findings likely are consistent with the experience of the average clinician. Topical diclofenac appears to offer the best balance between benefit and harm for knee osteoarthritis, although this agent has been relatively ineffective in my anecdotal experience, according to the reviewer. In the end, pharmacological approach to hip and knee osteoarthritis generally is trial and error. And this is the reference, Da Costa BR et al. Effectiveness and safety of non-steroidal anti-inflammatory drugs and opioid treatment for knee and hip osteoarthritis, network meta-analysis, BMJ 2021, October 12.
Okay, that concludes the third presentation. And the keyword number 3, or the third keyword, is arthritis. Okay, the third keyword is arthritis, and it's all in lowercase as well.
Antibiotics required for mild acute diverticulitis. And this is a review of the paper by Mora Lopez in the Annals of Surgery 2021, November. The short summary: antibiotics did not improve outcomes in a randomized outpatient trial. Okay, 3 randomized trials have shown no difference in outcomes between antibiotic treatment and no antibiotic treatment for patients with mild acute diverticulitis, and that's from the British Journal of Surgery in 2012, in 2017, and the NEJM in 2020, and Clinical Gastroenterology Hepatology in 2021. However, because these trials involve hospitalized patients who might have received other beneficial interventions, such as vigorous intravenous hydration, some critics argue that their results might not apply to outpatients. So now Spanish researchers have conducted a randomized trial that involved 480 outpatients with no significant comorbidities who presented to emergency departments with uncomplicated acute diverticulitis, i.e., only wall thickening and increased density of pericolic fat on computed tomography. The patients receive either amoxicillin clavulanate or no antibiotic. And during 3 months of follow-up, there was no significant difference between the antibiotic and no antibiotic group in hospitalization rates, 5.8% versus 3.3%, and return visits to the emergency department, 7% in both groups, or pain control. And no patient in either group required surgery during follow-up. So the comment by the reviewer, once again, a clinical trial has shown that antibiotics did not improve outcomes in patients with mild acute diverticulitis. Although a recent US guideline permits clinicians to use antibiotics selectively rather than routinely in mild diverticulitis, a popular medical reference continues to recommend antibiotics routinely, and most clinicians continue to prescribe them. The community standard of practice in the US likely won't change until guidelines and medical reference texts align with strong endorsements of non-antibiotic approach to these patients. And this is the full reference, Mora Lopez et al., Efficacy and Safety of Non-Antibiotic Outpatient Treatment in Mild Acute Diverticulitis, the Dynamo study, a multi-center randomized open-label non-inferiority trial in the Annals of Surgery 2021, November.
Okay, that's the fourth presentation. And the fourth keyword is diverticulitis. Okay, all in lowercase again. The fourth keyword is diverticulitis.
Is measuring D-dimer helpful in hospitalized COVID-19 patients with suspected PE? And this is a review by the paper by Logothesis and et al. In the JAMA 2021, October 8. A normal D-dimer level excluded pulmonary embolism, but elevated D-dimer was almost universal in COVID-19 patients. So clinicians have long relied on a normal D-dimer level in conjunction with low to moderate clinical prediction scores such as Wells and Geneva to rule out pulmonary embolism. So COVID-19 patients are at excessive thrombotic risk, and whether D-dimer measurement is useful in this population is unclear. So researchers in Florida retrospectively reviewed data on 1,500 consecutive patients hospitalized with COVID-19 from January 2020 to February 2021. A total of 287 patients underwent D-dimer testing and computed tomographic pulmonary angiography or CTPA for evaluation of pulmonary embolism. 37 or 13% had PEs. All positive CTPA patients had elevated D-dimer levels, more than 500 nanograms per milliliter. However, most patients, 91% without imaging identified PE, also had elevated D-dimer levels, although levels in this group were not as high as in the positive PE group. So the comment was, although the researchers did not report any clinical prediction scores, with a PE incidence of 13% in this population, we assume this cohort would have fallen into the traditional low to intermediate PE risk category before accounting for additional COVID-19 prothrombotic state. Even given the limitations of this single center study, it is reassuring that no COVID patients with normal D-dimer levels had PE, i.e., there is a 100% negative predictive value, of a normal D-dimer level. So clinicians can feel confident that in hospitalized patients at low to intermediate risk, normal D-dimer levels can be used to exclude PE in both COVID-19 and non-COVID-19 patients. However, only a small portion of COVID-19 patients will have normal D-dimer levels. And this is the reference, Logothetis, CN et al., D-dimer testing for the exclusion of pulmonary embolism among hospitalized patients with COVID-19 in the JAMA Open Network 2021, October 8th.
Okay, and that's the last and final journal presentation. And the fifth keyword is pulmonary. Okay, the fifth keyword is pulmonary, and again, all in lowercase. So I hope you got all 5 keywords. The link to the how you can access that you've been following the whole 5 presentations and how to get points is provided in the Telegram group. Okay, I hope this works out well for you, and I hope you enjoyed the 5 articles which we've selected, which thought will be of interest to you. Okay.